Okay, you can see the recording icon?
Yes.
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 Yes,
So,
so
fantastic. So let's talk about mesothelioma. Mesothelioma is a difficult disease. Unfortunately, in India, you don't see as much of mesothelioma as we see in the Western countries. So a lot of people find it difficult. What are the guidelines? What are the protocols? So as you know, I will always talk from guidelines. So everything that I'm going to say in this slide is backed by evidence, is backed by papers. Okay, so you can safely quote any single line from my presentation, because everything that I say is backed by evidence. So this is today's talk is all based on the NCCN clinical practice guidelines of malignant pleural mesothelioma. So I'll try and take you through all of the things, make you understand what it is. We'll try and understand the etiology of the disease. We will then talk a little bit about how to investigate a case of mesothelioma, and then we will talk about what are the treatment options available to us. Okay, and I've tried to go into depths of each of these subsections so that you understand and take away complete concept of mesothelioma. But this is the paper you have to read, and the most important thing is everything that I'm saying today is actually version 1 2020, which means this is the most up-to-date information on mesothelioma. So the whole discussion was finalized just last month. So everything that I'm saying is up to date in literature. So please, anybody who's giving their FRCS exams this year, feel free to quote my presentation and everything will be up to date with the literature. Okay, so let's look at what is mesothelioma. We all understand mesothelioma is a malignancy which arises from the mesothelial surface of the pleura. Commonest area that you see mesothelioma is in the pleura, 81%, but mesothelioma can affect other lining membranes of the body, and amongst them is the peritoneum. So pleura and the peritoneum make up most of the cases. Almost 90% total would be either pleural cases or peritoneal cases. The other place where you can actually get a mesothelioma is in the pericardium. You can either get pericardial mesothelioma as a secondary pathology to pleural mesothelioma, and there are incidental case reports of primary pericardial mesothelioma. Very, very, very rare. And the one more organ which actually surprisingly can be affected by the asbestos exposure and cause mesothelioma is the tunica vaginalis of testes. Very, very unusual, but it has been reported 1 to 2% of cases actually turn out to be testicular mesothelioma. So that is something new, which is very much reported in the literature. Okay. Now let's start off directly with the mortality, because this is a very morbid situation. So in the US, in the early 1980s and 90s, the mortality was shooting up, because what you have to realize is that whatever mesothelioma that we are seeing now, it is because of an exposure about 20 to 30 years ago. Okay, so minimum 15 to 20 years ago, these people were exposed to asbestos fibers, and it takes that much time for the fiber to create the irritation and turn into a malignancy. So almost all of us, particularly in the UK and the US, have seen a peak of mesothelioma. We are going through an epidemic of mesothelioma because the shipping industry was very, very strong in England particularly. And I trained in Southampton, and Southampton was close to, is a port town, as is Portsmouth. And almost 50% of the population of Southampton and Portsmouth actually worked in the docks. So we saw an epidemic. In fact, we are still seeing an epidemic. And in the early 80s, 90s, and 2000s, the mortality was pretty high with mesothelioma because we didn't really have any methodology to treat them, and more importantly, we really didn't have any good methodology to diagnose mesothelioma. But now, coming into 2020, the epidemic mortality has actually stabilized in the US. It is on the rise in Russia. Western Europe, China, and India. So these countries are yet to see, the cases, the hardcore cases of mesothelioma, but in the next few years, they will see more and more cases of advanced mesothelioma, purely because of the disease, because of the exposure pattern that has happened over the years. The mortality currently is the highest in UK, Netherlands, and Australia. Ravi Kumar, did you raise your hand? If there are any questions, just keep it till the end so that I can finish the talk and then I will answer these questions. So don't raise your hands. Okay, so the mortality currently in the world is highest in the UK, Netherlands, and Australia. US has stabilized. But there are still some people who are producing asbestos, and predominantly the 4 countries that are featured who are still producing asbestos are Russia, China, Brazil, and Canada. So there is still a little more of WHO guidelines to be pushed in, because obviously there is a business aspect to this which people don't want to give up on. So what are the risk factors? The most commonest risk factor, and almost everybody will tell you this, is asbestos exposure. That is the important thing to remember. So what is the type of asbestos that you are exposed to? In addition to asbestos, I'll talk about that in a minute, sorry. In addition to asbestos exposure, the other risk factors for malignant pleural mesothelioma is a history of radiotherapy to the chest. Particularly radiotherapy for Hodgkin's lymphoma. The problem with this was a lot of these patients received radiotherapy in the early 2000s or early 1990s, and at that time we did not have these high beam CTs or SBRTs and things like that. So most of the radiotherapy was high dose and given as a broad spectrum. And so usually you had a big wallop which was received by the mesothelioma, and that actually is now, which is received by the pleural membrane, and that is now presenting itself as mesothelioma. People who work in the construction industry are exposed. They're exposed to a ion which is called as erionite, which is present in the gravel roads, and this is also known to predispose to the formation of mesothelioma. There is a genetic predisposition for mesothelioma. There are a couple of studies which have looked at the presence of BRCA1 associated protein. It's called as BAP1, BAP1, and BAP1 has known to be associated with the presence of mesothelioma. So this is current literature which has come out of China and Japan, and they've looked at these things. Smoking is not directly a risk factor. So that's important to understand that smoking actually causes lung cancer, but is not directly a risk factor for mesothelioma. But smoking plus asbestos exposure is known to be a risk factor. Okay, so you got to be, there are a couple of papers which have actually done a analysis of risk factors, and they have actually come up that smoking directly does not cause mesothelioma, but a combination of smoking plus asbestos exposure is a risk factor for mesothelioma. There is some work which has looked at the virus exposure. There is a virus called as SV40, and we'll talk about this in a minute. It's simian virus 40. But let's look at asbestos first, see what does asbestos cause. So there are various types of asbestos fibers. There is something called as amphibole fibers, which are present in blue asbestos. So it's called as crocidolite. So this is supposed to be the most carcinogenic. It is the amphibole fiber present within the blue asbestos and the brown asbestos that is the high risk for mesothelioma. So crocidolite or amosite, these are the two names for the two types of asbestos. Surprisingly, the white asbestos which we see in our day-to-day life, there is really not enough evidence at the moment to correlate the white asbestos, which is a chrysotile, with mesothelioma. There is still a lot of debate going on that. But if you are asked in the exam, what is the type of asbestos fiber, you have to say amphibole. Okay, that's the one that's associated. The problem with the fibers are these are insoluble. They do not actually get destroyed either in the body or outside the body. So unfortunately, these fibers go into the circulation because you inhale them, and then they go into the pleural area. They get into the circulation, and they form a fibrous reaction on the surface of the pleura, and the fibrous reaction gives rise to plaque. Now, important to understand that every plaque is not a mesothelioma. A plaque is a benign disease, but people who have plaques have a risk of going on to have mesothelioma. But actually, there is no data at the moment to tell us which is the correct, what is the duration and who will actually develop mesothelioma and who will not. So just because you've done a VATS and you've seen for some other pathology and you saw the presence of a plaque, do not diagnose these people as mesothelioma, okay? So it's quite important to differentiate between the two. They are two different pathologies, okay? The simian virus 40, which I told you about, is actually a DNA tumor virus. It acts on the DNA of the native host, and it causes carcinogenic change in the DNA. And in the labs, they have looked at its potential carcinogenicity, and they have actually been able to recreate mesothelioma in hamsters. So the presence of a simian virus 40 is not a direct cause of the mesothelioma, but there is association of SV40 with mesothelioma, particularly for God's sake, please switch off your microphones, please. Whoever has got it on, switch it off. That's the first rule of the game. Switch off your microphone.
हाँ, मेरे को भी first time के हिसाब से अच्छा बना.
Sumit, will you please switch off your microphone? Sumit?
Yes, sir.
Thank you. Okay. So mesothelioma, SV40 is a risk factor for mesothelioma in hamsters. The suggestion is that it stimulates the production of growth factors and it inactivates this genetic number, RASSF1. And it is the inactivation of the RASSF1 which actually makes the asbestos into a carcinogen. So there is this suggestion that asbestos with an increased SV40 mediated pathology transforms a normal pleural epithelium into a mesothelioma. So this is the philosophy behind the SV40 theory. But still, we are not so sure about this. This is still all lab work that has been looked at. So there is a suggestion that these two may be co-carcinogens rather than the SV40 causing a cancer straight away. Okay, so what are the types of mesotheliomas? The first type is epithelioid. Epithelioid are better outcomes, sarcomatoid, and mixed. The NCCN guideline talks only about the top three types. Okay, in all the guidelines, it talks predominantly about epithelioid, sarcomatoid, biphasic, which is epithelioid plus sarcomatoid. Histologically, there is a diagnosis of desmoplastic histological subtypes, but the NCCN guidelines has focused predominantly on the top three. The important thing to remember is that unlike lung cancer, where we have some evidence, the IEL CAP study and the other studies to say that screening may be a tool for lung cancer, there is no effective tool for screening in mesothelioma. There is absolutely no evidence to suggest that doing a follow-up CT in people actually can help you diagnose mesotheliomas. So it is really low-dose CT screening does not improve mortality or improve survival in the cases of mesothelioma. And this is of the NCCN guidelines. There are about 5 papers which have looked at this. So if you're ever asked about screening for mesothelioma, the answer is no screening, because LDCT is not an effective tool. Okay, LDCT is low dose CT. So this is an important question. It comes in the MCQs sometimes in a twisted way. And you think that screening may be a good idea, but actually there is no evidence to suggest that it does anything, and it adds to the cost of healthcare. Okay. Now, NCCN has come up with a beautiful patient guide. Okay, it's just absolutely one of the most amazing documents that you will read. And lot of pictures that come in today in my talk, I have put in from the patient guide, because this will help you understand the subject very clearly. This is the most simplified pattern of what is out there in mesothelioma. So they have given this patient guide where they say epithelioid is like cells are uniform, but they form complex organized patterns. Sarcomatoid, the cells are spindle shaped, but they are disorganized. That is why sarcomatoid has a much worse prognosis than an epithelioid. And biphasic is a mixture of the two, sarcomatoid and epithelioid. And you will see these flashcards coming through my talk purely because I want you to understand the subject in layman's term so that you can then reproduce it in your clinical practice. Okay, so what are the symptoms of mesothelioma? Now, the one thing you've got to remember is mesothelioma as a disease, in more ways than one, has pretty drastic symptoms. So even though you might have less volume of disease, your symptom may be very high because of involvement of the chest wall. And pain can very quickly, or shortness of breath can very quickly take you to the doctor. But it doesn't mean that you pick up the mesothelioma early. Unfortunately, that correlation is not there. So the symptoms of mesothelioma are dyspnea, chest pain. The dyspnea happens because of pleural effusion. Chest pain happens because of involvement of the parietal pleura. Pleural effusion causing these symptoms. In addition to that, there will be fatigue, insomnia, cough, chest wall mass. If there is a chest wall mass, it means that the mesothelioma is growing between the rib spaces and forming subcutaneous masses. That's not a good sign. If you've got a chest wall mass, not a good sign at all. Loss of appetite, because usually this causes systemic effects of malignancy. And very quickly, these people seem to lose appetite, and they seem to have weight loss. So these are pretty sort of drastic situations where you might have to intervene in these patients. So this is the patient guideline. This was the patient flashcard, very beautifully presented, saying you might have trouble breathing, which is dyspnea. You might have chest pain. You might have cough that is not getting better. You might have a mass under the skin in the chest. You might have fatigue, lethargy, tiredness. You might have unplanned weight loss. Unplanned weight loss is pretty common with mesothelioma. We've seen a lot of patients who lose weight pretty drastically with mesothelioma. Or you may have insomnia. So these are the flashcards of the symptoms that the patient will have. So if you're writing in an exam, particularly for your DNB, this flashcard will help you to remember the symptoms. So it's a good way to make it easy and identify the symptoms in the exams. As I said, the symptoms are higher burden than other cancers, because lung cancer, you might have a large lung tumor before you actually show any symptoms whatsoever. So that is actually bad because you cannot pick it up. But these usually might present with a higher burden, and they may present without metastases. So even a local disease will present you with symptoms which will be pretty diagnostic. And the most commonest symptom, as I said earlier, is chest pain and acute dyspnea. The chest pain occurring because of invasion into the chest wall, and the dyspnea occurring because the pleura is involved. There's an inflammatory response, and as a secondary fact to the inflammatory stroke malignant response, there is increased pleural collection, and that progressively makes the patient short of breath. Both of these are indicative of local disease. So this is one characteristics of mesothelioma, that surprisingly they give you more symptoms when you are when there are local disease and without metastases. How do you diagnose? Now look at NCCN. He's talking quite clearly about diagnosis. So I'm going to just enumerate how they are going to talk about. So you have a chest X-ray or CT scan with contrast. That's the first step. Most of these people will have some evidence of pleural effusion. And the moment you have evidence of pleural effusion, you go in and do a thoracocentesis. When you're doing a thoracocentesis, you send the fluid for cytology, microbiology, but at the same time, if you can, preferably go in by VATS and do a pleural biopsy. The pleural fluid may usually be negative on cytology. That's the other thing to remember, that the pleural fluid may be negative. It's very difficult to get malignant mesothelioma cells in a pleural fluid. And that is why when you take a biopsy, you have to take, there's a special way of taking the biopsy. Who is doing this? Somebody is fiddling around with the background. Just stop it, please. Because this is a meeting, you have control of my presentation, so you can actually make changes. So whoever is fiddling around, stop. FNAC is not recommended. Okay, FNAC is not the way to go. You actually have to do a VATS pleural biopsy. And one of the markers, the biomarkers, which NCCN guideline clearly states, is soluble mesothelin related protein, SMRP. And this protein correlates with the disease status. And so nowadays, increasingly, they're starting to use SMRP as a biomarker for mesothelioma. And I'll talk about biomarkers in a second. Okay, so this is the SMRP data. Very pretty sensitive for diagnosing the presence of mesothelioma, but the problem is the value or the number does not correlate very well with sarcomatoid mesothelioma. So in other types of mesothelioma, it is elevated, but sometimes in sarcomatoid mesothelioma, there may not be that much of an elevation. And so you may actually not be able to diagnose purely on the basis of SMRP. Hence, they say the biomarkers are not to be used isolated. You have to use the biomarkers in association with other things like chest X-ray, CT scan, and pleural biopsy. So it is biomarkers in mesothelioma cannot be used isolated. It's the trade name for the SMRP is Mesomark. So you send for a test which is called as Mesomark assay. And Mesomark assay is the only biomarker which works well at the moment, according to the latest literature. But I'll tell you about all the other biomarkers. So let me go through each one of these biomarkers. Each one of them has papers which are claiming that it has benefit, but none of those papers are RCTs. They are not randomized controlled trials. So it's very difficult, if it's not a randomized controlled trial, to include it into a guideline for general doctors. So these are the biomarkers. One is Mesomark, which is SMRP. The other is NERC, which is also called as a mesothelin test. This is a protein which is secreted by the mesothelioma. And when the blood is sent to the lab, they use an antibody to the mesothelin, and the reaction of the antibody to that mesothelin protein is interpreted by an assay to give you a percentage. So it gives you a percentage activation. The thing about biomarkers is these are not normally present in the blood. So that is why they have come into the picture. Because if you got something which is normally present in the blood, then it's very difficult to find out, the close association with the cancer. So these markers are not normally present. Hence, they have a better sensitivity to tell you the presence of cancer. But at the moment, we have got no randomized controlled trial to test the validity of this sensitivity and specificity. The other biomarker that is available is fibulin. So when you write in your exam, please remember these names. This is good for theory, not so good for practice. Okay, but in the vivas, we could ask you, what is the biomarker that you know of? And Mesomark is the only one. SMRP is the only one that you should talk about. The other one is osteopontin test. So this is again no sensitivity available at the moment. There is something called as megakaryocyte potentiation test. There is lesser information on these ones. These will actually come up in future now. So ATHDG, estrogen receptor beta, epidermal growth factor receptor, which is EGRF. I'm sorry about the 9, it was supposed to be a bracket. Osteopontin test, I said, and then calretin, calretinine. Okay, so calretinine is another test. Calretinine in the blood. We are not talking about immunomarkers. Okay, we are not talking about immunohistochemistry, because calretinine is used in immunohistochemistry in histology. But here we are talking about blood biomarkers assay. So calretinine also appears in the blood in mesothelioma. So these are the ones that you need to remember. I'll just quickly show you the 2 slides. So mesomark, MERC, which is a mesothelin test, fibulin, osteopontin, megakaryocyte potentiation test, ATSDG, estrogen receptors, EGRF, osteopontin, and calretinine. Okay, so just if you ever get asked for the question on blood biomarkers, this is the data just set out for you. Okay, so this is the flashcard for the patient to understand. So the 4 things that NCCN guidelines speaks about is CT chest. Actually, in the guidelines, it also talks about chest X-ray, but a contrast enhanced CT chest, not an HRCT. Okay, remember this. I think yesterday or day before we discussed the first line of management in lung pathology is HRCT. Here we want to see the pleura. We want to see the correct delineation of the pleura. Hence, you have to use chest CT with contrast. There's a difference between the two, and it's important to understand it's CECT. Thoracocentesis is there in the guidelines. You can either put in a needle and get aspiration fluid and send it for cytology. But again, the sensitivity is not so great. But the best one is pleural biopsy. Again, pleural biopsy to be done by VATS. Either you can do it as medical thoracoscopy or you can do it as surgical thoracoscopy. When you do either, you must include Talc Pleurodesis for symptomatic control. And then, of course, the SMRP blood test. So this is what you have to answer in the exam. This is part of the NCCN guidelines, okay? So this is a standard chest X-ray that you do. You can see there is some evidence of haziness, some opacity at the apex here. There are some changes along the margins here. You can also see some sort of a nodular appearance in the margin here. So all of this is suggesting that there's something wrong with the pleura. And the moment you see something like that, you got to send the guy for CT scan. Now, very often in a CT scan, for other diseases, you will see this. You will see the presence of a plaque. The presence or absence of a plaque does not represent mesothelioma. That's the important thing to understand. That just because he's got a plaque does not mean that he's got mesothelioma. You actually got to see pleural thickening. So this is what you would see. This is pleural thickening all around. And if I played the whole CT, it is from the top to the bottom. And there is effusion in this patient. And most of the thickening is along the parietal pleura. Can you see that? And this is a nodular appearance. This is classic. If you ever see this nodular appearance in the pleura, particularly involving the mediastinal pleura, then this is suggestive of a mesothelioma. And I would very urgently want to biopsy this guy. And needle biopsy is not so good. So I would actually go in either by local anesthesia thoracoscopy, medical thoracoscopy, or VATS and biopsy this pleura. Very important, okay? Very often when we do the VATS, we go in there and sometimes we see these multiple nodules. The reason why you have to biopsy is that these nodules could also be metastatic adenocarcinoma, okay? So you have to biopsy the nodule to know whether it is lung cancer or is it another adenocarcinoma from the bowel or something, or is this primary mesothelioma? Whenever you biopsy, don't forget to send tissue for microbiology and more importantly, tissue for TB culture, because sometimes TB can also give you this miliary appearance. But in this particular situation, because all of the lung is involved and the nodules seem to be quite classical of what we see in mesothelioma. And if you look carefully, you will also see a plaque. Can you see this plaque here? So the plaque also gives you a suggestion that this guy may have been exposed to asbestos. So the suspicion has to be very high. Sometimes you just see a diffuse change like this. You may not see these nodules very clearly. Sometimes you see a diffuse change. The mucosa looks erythematous with multiple punctate marks seen here. And you've really got to have a high suspicion when there's a global change in the pleura. The other important thing when you do a pleural biopsy is how to biopsy these lesions. So there are two types of biopsies. One is a punch biopsy, where you take a crocodile forceps or a long biopsy forceps, go in and take a punch biopsy. But better than a punch biopsy is a peel biopsy, where you make a hole in the pleura, dissect subpleurally, and take a whole peel off. Because the one thing that can happen in a punch biopsy is you might end up punching into the intercostal artery or the intercostal nerve. So that's not such a good idea, because that'll unnecessarily cause bleeding or pain. So a peel biopsy is more recommended for mesothelioma. Most important thing, I have seen this hundreds of times when my registrars are operating, that they will go in and just try to biopsy the plaque. Many times I've seen that. They go in there and they just get into the middle of the plaque and try to punch the plaque out. It is very hard. B, it will break your biopsy forceps. And C, it will give you the least yield of histology. So the correct place to biopsy is actually at the edge of the plaque. It is the vascularity at the edge of the plaque which undergoes malignant change, and which will also show the presence of asbestos fibers in the blood vessels when you look at it histologically. So you must biopsy the edge of a plaque, not the middle of the plaque. And most important thing is not a single biopsy. You've got to take at least 5 to 10 different areas, because very often, because this is a discrete change in the whole pleura, and the pleura is a large surface, some place may have infection and inflammation, and another place may have malignancy. So it is very important to biopsy at least 5 to 10 areas around the pleura, so that you get a representative sample, and then your histology coming back positive for mesothelioma will be increased. Okay, so it's important. It's not just a simple go in, just punch it out. You have to think about how can you help the pathologist to give you a diagnosis of mesothelioma. It's a very difficult disease on histopathology as well. They really need to look carefully before they can commit to a diagnosis of mesothelioma. So the bottom line in this is that tissue is the issue. So make sure you take many biopsies and send as much biopsy as possible to the pathologist. There is a direct correlation. Some papers have looked at it, and there's a direct correlation with the number of biopsies versus histologically positive diagnosis of mesothelioma. So very important to take more than one biopsies. So this is what we call as a punch biopsy. And if you actually dissected into the subcutaneous plane, into the subpleural plane, and took a peel off, then that would be a peel biopsy. Whenever we are there by VATS, most of the times, if we find that the lung is expanding, we will actually put in talc to allow pleurodesis. So at least the patient gets symptomatic relief. Also, eventually, when you are going to offer these guys surgery, presence of talc and pleurodesis actually helps with extrapleural pneumonectomy dissection. So it's therapeutic at that moment for the patient, and also helps surgery in the long term. Okay, so this is something that we need to do. Now let's look at, so far are we okay? Everybody's understanding what I'm saying? Just one or two.
Yes,
Are we okay?
right.
Yeah, I'm all okay. So far so good. All right. So now we get into the next stage. So we've done the basic clinical stuff. We've looked at the symptoms. We've looked at how we are going to biopsy, and we've looked at how to reach a histopathological diagnosis. Now this is very confusing. A lot of people do not understand the TNM staging of mesothelioma. And this is the way we decide what is the treatment protocol for the patient. This is the 8th TNM. Okay, this is the 8th edition of TNM staging for mesothelioma, and this comes from the International Mesothelioma Interest Group, IMIG. They are the ones who worked on this, and they produced this document, and then this document was taken up by the AJCC committee, and so this has come out as AJCC TNM staging based on IMIG recommendations. Okay, so this is what it is. Now let me just go through each one of this in more detail and explain to you what is the difference between the 7th and the 8th edition of AJCC. So let's look at the first T staging. The most important thing is T staging. Now this is a very sort of a easy picture to understand. That's why I put it up here. This is called as a SIMLAP. A SIMLAP is superior, inferior, medial, lateral, anterior, and posterior. This was a sort of a easy staging system that they had put up to understand what is a T staging of the mesothelioma. So what you have to do here is look at the colors. Okay, so yellow, T0. That means it's just on the pleura and nothing more has happened. The green represents intrapleural spread, okay, along the parietal pleura. Can you see that? Okay. The blue represents invasion into the parenchyma of the lung and lobar space. The purple represents invasion into mediastinal structures. Can you see that? The purple represents invasion into mediastinal structures or outwards into the chest wall. And the red represents metastatic spread into anything and everything, including the contralateral. So when you look at yellow, which is just localized tumor, it is T0. If you look at green, which is spread vertically or inferiorly, superiorly or inferiorly along the parietal pleura, it is T1. If you look at blue, which is invasion into the visceral pleura, it is T2. If you look at purple, which is going across either into the mediastinal fat or into the chest wall, can you see that? It's going into the chest wall, that is T3. And then T4 goes all the way to the organs in the mediastinum or goes to the contralateral pericardium. This is a simple way. It's called as the SIMLAP way of understanding the T staging of a mediastinum of mesothelioma. So let's look more carefully on that. So you've got X, where primary tumor could not be assessed. T0, which was the yellow part of that thing, no evidence of primary tumor. T1, which is tumor limited to ipsilateral parietal wall, with or without involvement of any of these. Okay, so it really does not, just touching the diaphragm doesn't make it T4. You can have T1 disease touching the diaphragm. It's the invasion through the diaphragm that changes the staging. So the ipsilateral parietal pleura, the key word is parietal pleura, can be present on the diaphragm, can be present on the mediastinum, and it can even touch the visceral pleura but not go into the lung. So this is the outer lining of the visceral pleura that we are talking about. Anytime it is just limited to the pleura, then it is T1. If you go beyond that, then it will be ipsilateral pleura, which is involving either mediastinal, parietal, diaphragmatic, or visceral. But one of these has to be present for it to become T2, and that is, it has to go through the diaphragmatic muscle. There has to be involvement, a subpleural involvement of diaphragmatic muscle or invasion into the underlying lung parenchyma. Did you understand that? Did this make sense? Hello?
Yes, sir.
Yes, sir.
Is it making sense? I'm trying to go a little slow. It's important to understand because treatment changes depending upon what is the staging. So it's the T stage which is usually difficult, where people get confused. So T1 we said was tumor limited to parietal pleura or visceral pleura or mediastinal or diaphragmatic pleura, but the inner lining, not going beyond it. The T2 is same, but it is now gone into the diaphragmatic muscle, or it has gone into the lung parenchyma. That is the difference in T2 and T1. T3 is technically potentially resectable tumor, which is involving the surfaces, the pleural surfaces, all the 4 surfaces, or any of the 4 surfaces. But more importantly, at least one of these features has to be positive for it to be T3. That means it has gone beyond the chest. At one point, it has gone into the extra thoracic facial plane, or it has gone into the mediastinal fat, or solitary soft tissue nodule in the chest wall, or there is involvement of the pericardium, but the outer lining of the pericardium on the mediastinal side. It has not yet gone through the pericardium. Does that make sense? And then the next step, once you have got this T3, then the next step is T4, where there is unresectable ipsilateral pleura, meaning all of this pleura may or may not be involved, but more importantly, there is multifocal chest wall disease. So in T3, it is unifocal chest wall disease. In T4, it is multifocal chest wall disease, or it has gone across the diaphragm. So in T2, you had just gone into the muscle of the diaphragm. In T4, you have gone across the diaphragm, or you've gone to the opposite pleura, or you've gone directly into any of the organs, or you've gone into the heart, okay? So it's quite important to understand that. I will again put up this picture, the first picture, to show you what it means, this one. So T0 is just localized to one spot or no tumor. T1 is when it is going along the pleura, the parietal or the visceral pleura, but not invading through the pleura. T2 is when it is gone into the parenchyma of the lung or gone into the muscle of the diaphragm. T3 is when it has gone into extrathoracic space, or it has gone into the mediastinal fat. And T4 is when it's gone into any of the organs. So this is how you classify the T staging of the tumor, okay? Now, let's look at what is the end staging. The end staging is actually quite straightforward. There is nothing complicated about the end staging. In the 7th edition, there was something called as N3. That N3 has been taken away, and now it is either no nodes or ipsilateral bronchopulmonary hilar mediastinal nodes, or metastasis into the contralateral nodes or supraclavicular. So N2 is contralateral or supraclavicular, N1 is any nodes, and N0 is no nodes. Very, very easy. So the N and M is easy to understand. So based on the T and M, you then get into the prognostic group where you want to stage the tumor, and the staging is stage 1A or 1B, then stage 2. Stage 3 is divided into A and B, and then stage 4. The understanding of this is that up to year, you can talk about surgery, okay? Even some 3A might involve surgery, but here it is all palliation. There is no surgery here. Is this clear? I won't go into details of which is which. You just look it up in your free time and try to figure out how it has become 1, 2, 3, and 4, okay? So this is the easiest way to understand now. I have gone the complex way, but this is for the patient. Now listen to what it's saying. It's saying the tumor, stage 1 is tumor hasn't grown beyond the pleura where it started. Okay? Stage 2 is the tumor has gone into the diaphragm or the pleura or both. Remember we said through the muscle or in the parenchyma of the lung. Stage 3 is when the tumor is in the first layer of the chest wall or confined to other layers, but more importantly, the fat between the lungs or the pericardium, and lymph nodes are starting to be involved in stage 3. Okay, this is the simplest explanation of that complex TNM staging. And stage 4 is when it has gone into anything else. Any organ that is involved or any lymph nodes beyond the normal sides or to distal side is stage 4. So this is the one that you need to catch hold of. And then really, moment you understand this, everything else becomes clear. Okay. So stage 1, stage 2, stage 3, stage 4. And then of course, when we talk in an MDT, we need to know what is stage 1A, 1B, 3A, 3B. This is for the layperson, for the general population to understand what does the various stages of mesothelioma mean. Okay, again, the same thing, just a pictorial representation of what exactly is stage 1, 2, 3, and 4. Very often we use this when we discuss with a patient to explain to them what is the stage of their disease. Okay, so now let's get into surgical staging. We said that this is the IMIG staging. It was approved by AJCC in 2018. The changes between 7 and 6 are T3 has been downstaged. I'll show you that in a minute. The N3 is now N2. N2 is now N1. And there is no 1A or 1B. It's now become T1. Just remember these 4 points and you're very happy with TNM. If in an exam I asked you what is the staging of mesothelioma, if you tell me these 4 points that has changed from the 7th staging, I'll be very happy. This will get you through the exam. T3 has been downgraded, N3 has become N2, N2 has become N1, and T1AB has become T1. So it's very, very straightforward. Only 4 points to remember about TNM staging of mesothelioma. Again, if you look into more details, this is the 7th one and this is the 8th one. Okay. So these are the differences between the two. Look here, there is N3. Here there is no N3. So this stage has moved up, that stage has moved up. So it's just a different staging system. Again, T3, this is the 7th group where this was T3. T3 instead of being 3B has moved up to 3A. This is the change in this. T3 was here. T3 now is 3A, particularly looking at N1 or N2. So T3 can be 1 or 2 depending upon N1 and N2. Don't go into more details about this. This is for the experts to understand. For you, just know the 4 points that I marked out, and that is good enough to do clinical practice with mesothelioma. Okay. Now, just for further completion, let me tell you there are other staging systems that are around. There is the Butchard system. Butchard was a very senior thoracic surgeon in Wales, in Cardiff, and he had done a lot of work on mesothelioma. He's one of the early guys. He's retired now, a very, very old man. And he is the guy who started with the concept of extrapleural pneumonectomy for mesothelioma. So he has worked extensively, and he's got a system of grading the mesotheliomas based on stage 1, 2, 3, and 4. Then we spoke about the UICC TNM. We spoke about the IMIG TNM. So the one that we are using is the IMIG TNM ratified by AJCC. And then there is the Brigham and Women or Dana-Farber's Cancer Institute staging. These are the 4 staging. This is only for theory, okay, not for clinical practice. We don't really use any of them except the IMIG TNM, okay? Okay, is it clear so far?
Yes, right. Thank you.
Yes, sir.
Yes, very clear.
Good, I'm
Yes,
happy.
sir.
Because it's a very confused, the TNM gets over your head. So I've tried to highlight just the important points of the TNM. Okay, so now let's get into the treatment part and look at what exactly the guidelines tell us. How should we go about treating these people? So as I always say, I always show you what is the category of the recommendation. So NCCN is based on category 1, 2A, 2B, and 3. Most of the recommendation in NCCN, if anybody asks you what is the level of evidence, just say 2A. Most of the recommendations have been based on 2A. So you're very safe to say 2A. There is here it says as well, all recommendations are category 2A unless otherwise indicated. So most of the recommendations that we discussed today are 2A. And it really makes your talk sound very professional. When in the exam you say, I'm going to do this based on the NCCN guidelines, recommendation 2A. And it really tells me that you're switched on and you're practicing what is called as evidence-based medicine. So the initial evaluation is a flow chart. We have gone through that, but I'll just go through it in a bit more detail. So this is what we wrote earlier and we spoke about it. So we've spoken about this, exactly the same thing: CT chest, thoracocentesis, pleural biopsy, pleural fluid may be negative, FNAC not recommended, and SMRP to be used. We spoke about this earlier. That's why I've gone through a little faster. So that's the first recommendation, level of evidence 2A. Okay, important, level of evidence 2A for all of these. Immunohistochemistry. Now, immunohistochemistry is important in mesothelioma, and there are certain markers which are quite specific, which when they come positive, give you more of an indication that this could be a mesothelioma. And the markers are calretinine, WT1, which is Wilms tumor 1, D2-40, and cytokeratin 5-6. And these are the markers, a combination of these markers, which actually tell you whether it's an epithelioid or a sarcomatoid mesothelioma. But these are the markers that are important. But more important than these markers coming positive is the negativity of TTF1 and CEA. Because very often the real differentiation is this metastatic adenocarcinoma versus mesothelioma. That is the key thing where immunohistochemistry helps you. So when you have got some of these markers present, but more importantly, when you've got TTF1 negative, then it is not lung cancer. Hence, it might be mesothelioma. Did you understand this philosophy? It's very, very important to understand. So it's not just the positive markers, but it is the negative markers that are very important, because colonic adenocarcinoma can metastasize to the pleura, lung adenocarcinoma can metastasize to the pleura, and mesothelioma can also present in the pleura. And the most diagnostic difficulty for the histopathologist is this primary pleural malignancy, or is it a secondary from either the lung or elsewhere? And so these markers help you. The combination of the markers, some positive, some negative, will actually give you a clue as to what exactly you're dealing with. And that is why frozen section in a mesothelioma is not a good idea, because there is not a hope in hell you will have any anesthetist in the world who will give you a frozen section diagnosis of mesothelioma. They always want to do immunohistochemistry to make you better understand whether this is mesothelioma or a malignancy or a metastasis. So mesothelioma should always, always, always be discussed in MDT. This is mandatory requirement for any treatment of mesothelioma. As a single clinician, you should never ever take a call on a mesothelioma because it's a very complex treatment protocol. And most importantly, the MDT must have all the components. So it should have radiotherapy, medical oncologists, surgeons, radiologists, and pulmonologists. This is a 2A level of evidence in the NCCN guidelines, but most other guidelines talk about a higher level of evidence, 1C, when we talk about MDT. And mesothelioma, in BARTS particularly, we have a specific time within our lung cancer MDT, which is dedicated to mesothelioma, and only mesothelioma cases are discussed during that MDT. Even the thoracic surgeon has to be a dedicated mesothelioma person. Not every Tom, Dick, and Harry can operate on a mesothelioma. So within our group, we've got David Waller who does mesothelioma. So it's very, very important that only dedicated people do mesothelioma. Now, few philosophies I'm talking about now. When you come to surgery for mesothelioma, surgery should never, ever be done alone. You cannot just say that I will operate on this patient and that's it. All treatment protocols, surgery has to be a combination of other modalities. It can be surgery plus radiotherapy. It can be surgery plus radiotherapy plus chemotherapy, which is called as a tri-modality treatment. Now, where you place surgery, whether you place chemotherapy before surgery is a different discussion. But in this slide, what I'm trying to tell you is never, ever, ever say, I have done surgery and that's it, you're cured and go away. Never ever is that situation available. NCCN guidelines clearly states it. This is straight out of the NCCN guidelines. So always, it is always a tri-modality or a bi-modality treatment, depending upon what you do. You have to very, very carefully select the patients. No patient of mesothelioma is straightforward. No patient is like, let's go ahead and operate and take this out. It is always, you got to really assess the disease pattern, because at the end of the day, whatever you do with surgery, the reality is you are never doing what is called as R0 surgery. That is the reality. No matter how big we talk about EPP and PD and all that, the reality with surgery is you are never doing R0 surgery. There will always be microscopic cells left behind. It's not, you might take out everything macroscopically, but there will always be microscopic cells left behind. So the philosophy of surgery is I should go in and try to do macroscopic R0. That is the philosophy. You must try to do macroscopic R0, but it will always be microscopic R1 or more. You don't know that. So this is important to understand. The good candidates for surgery are clinical stages 1 to 3A, but more importantly, in assessing a patient for surgery, you have to look at the performance status of the patient. If the patient doesn't have good performance status, if he has huge amount of weight loss, if he's got malignant cachexia, he is not a candidate for surgery. And usually these guys are old. They're elderly patients that you see. And so you got to be very careful about analyzing the performance status of the patient. So PFTs come into the picture quite a lot. You really need to make sure that they've got adequate reserve to be able to undergo this surgery. What about radiotherapy, the philosophy of radiotherapy? Definitive radiotherapy alone is not recommended. Okay, it's not recommended, whether for resectable or unresectable mesothelioma. You cannot use radiotherapy alone. The same philosophy as surgery, you cannot use radiotherapy alone. And I'll talk about it in a minute about further indications of radiotherapy. The third philosophy is for chemotherapy. What do you do? Chemotherapy can be used alone in unresectable mesothelioma. That means you've said that the tumor has invaded. I cannot operate. I will not be able to do a macroscopic R0. Then you can give these guys chemotherapy, but again, to tolerate chemotherapy, their performance status has to be 0 to 2. The moment you get into performance status 3 and 4, you are actually getting into palliative treatment. You should not give high dose chemotherapy for these guys. Very important to understand this philosophy. And chemotherapy is used in tri-modality therapy with surgery, or sometimes it's used alone in patients who refuse surgery. So chemotherapy can be used in unresectable mesotheliomas, or can be used in patients who refuse surgery, who are potentially operable, but they don't want the risk of surgery, because the risk of surgery are pretty high with this disease. So let's look at the next big guidelines that they have spoken about in terms of pre-treatment evaluation. This is of the NCCN. So we have gone to the first stage. We are now in the second stage where we have diagnosed it. And now we want to do a pre-treatment evaluation of this mesothelioma. And the best way to understand is, again, back to the patient flashcard. So the recommended tests before surgery, according to NCCN, are number 1, a PET scan, because you do want to know what is the presence of distant metastases. That's quite important. It's not for the primary disease, but more so for the distant metastases. You do want to know what is the stage of the lymph nodes, because presence or absence of lymph nodes make it operable or inoperable. So it's quite important to understand what is the stage of the lymph node. That is why EBUS FNA or a mediastinoscopy, if need be, needs to be done pre-operatively or pre-treatment. We're not talking about pre-operatively, we're talking about pre-treatment. PFTs are mandatory because they give you a good inclination on what is the performance status of the patient. Sometimes you might even use perfusion scanning of the lung to understand what is the baseline lung capacity of this patient. Is he going to be fit for surgery or not? And most importantly, because whatever therapy you give will cause cardiac toxicity, you need to know the baseline cardiac evaluation, and you can even go up to a cardiac stress test if required. So the whole gamut has to be done before you can decide whether this guy needs chemo, radio, surgery, or tri-modality. So you have to do the whole thing. And this is a beautiful flash guide which clearly tells you what are the tests to be done. Okay, so let's go through the guideline now. Step back into the guideline. So they've spoken about chest CT and also abdominal CT, because you really want to know the transdiaphragmatic spread into the abdomen, or whether you've got associated peritoneal mesothelioma. FDG PET is good for surgical patients, but usually should be done before pleurodesis, because if once you've done pleurodesis, everything lights up. And so it's quite difficult for you to assess what exactly is happening. And for primary disease, not the metastasis, but for primary disease, it helps you differentiate between the presence of a plaque versus malignancy. So plaques are not lit up by FDG, whereas malignant areas will be lit up by FDG. So they are pretty good tests for surgical patients. Gives you an indication of the extent of the disease spread. PET scan frequently understages, which means that the tumor may look just as if it is stopping at the chest wall, but very often the tumor may actually be invading into the chest wall. So you have to understand the limitations of the PET. The PET scan may not show you vascular invasion or invasion of an organ. So just, you cannot interpret invasion on the basis of PET scan. It's good for metastasis, we said that. But very often, if you are actually going to put these people through surgery or through combined modality treatment, you might actually have to look at the other side. So you might have to do a VATS on the other side, contralateral side, to make sure there is no mesothelioma on that side. Or you might have to do a quick laparoscopy of the peritoneum to make sure there is no peritoneal mesothelioma. The moment any of this comes back positive, this guy is not for surgery. The last thing you want to do is a huge extended extrapleural pneumonectomy or even a pleurectomy decortication on this patient and then find out that the other side had mesothelioma. That would be a huge disfavor, and more importantly, it's an issue of medical negligence. So very often if there are subtle changes on the other side, because you've got to remember asbestos doesn't affect one side, it can affect both sides. So the CT may show disease on one side, but it may show some irregularity on the other side. So you really need to assess them preoperatively before you decide to put them through surgery. And of course, we spoke about the mediastinal lymph nodes, and EBUS FNA is the one that is spoken of in the guidelines. The guidelines directly mentions use of EBUS FNA, level of evidence 2A. Okay. The other things are laparoscopy for transdiaphragmatic extension. We spoke about it in the last slide. Chest MRI. Now, this is another indication for chest MRI where actually it's not for the chest, but the chest wall. You want to actually look for chest wall and vascular invasion. And MRI might actually give you a very, very good indication of whether the tumor is going into the thoracodorsal fascia, or if it is going into the vessel or is breaching the adventitia of the vessel. So chest MRI can be used in a pre-treatment evaluation. So you particularly want to look at the chest wall, spinal cord. You want to see the spinal cord. Diaphragm, very good, because MRI gives you a clear delineation of the tumor invading into the muscles of the diaphragm. If it's a transdiaphragmatic, it's easy, but when it's talking about invasion into the muscle of the diaphragm, an MRI works very well. And of course, to look for vascular involvement. So MRI is also part of the protocol. Again, this is from the NCCN guidelines. So you can safely say these things without worrying. So here we are going through all of this. That's the same guideway. Now let's go further. I'm not sticking to this. I'm going to highlight each part of it as we go along. So this is the treatment option. Once you've done all of these evaluation, what is the treatment? How do you do treatment? So we finished this part that was before. We've done the pre-treatment evaluation. Now, how do you do treatment? There is chemotherapy, there is surgical exploration, there is radiotherapy. It's quite a confusing chart, But again, I find the flashcard to be the best one. It's so beautiful and so clearly explained. So let's go through this. First question you have to ask, it doesn't start here, it starts here. The first question you have to ask is surgery possible? Okay, so the second question comes in. Is surgery possible? If it is possible, then you give them neoadjuvant chemotherapy. Okay, so if surgery is possible, you give them neoadjuvant chemotherapy. Once they have had a neoadjuvant chemotherapy, you reassess and then look at this option. You have two options for surgery. One is either a pleurectomy and decortication, or you have an option for extrapleural pneumonectomy. Just the top two. Okay, so if surgery is possible, yes, chemotherapy is received and then reevaluation, and then the patient goes for PD or EPP. Following the surgery, you make an evaluation whether this patient is fit or not fit. Then he will either go for no treatment or he will go for a tri-modality. Most of the times, this tri-modality was followed as a part of clinical trials. Okay, so very often these patients were in a clinical trial, and so they went for either tri-modality with radiotherapy or bimodality without radiotherapy. But this is an option available to the patient. The next answer to that is surgery possible? The answer is no. If the surgery is not possible, then you do not do anything of this. You just go directly to chemotherapy. There is no adjuvant chemotherapy. You just give chemotherapy as a primary treatment. So here we have understood the role of chemotherapy. Chemotherapy can come in as a primary treatment by itself, or it can come in as a neoadjuvant treatment for trimodality therapy. Okay. Now the next group is where you don't give neoadjuvant. Surgery is possible, but you are not giving neoadjuvant chemotherapy. You're actually giving chemotherapy following the surgery. So if it is a low dose, low volume tumor, which you think you can surgically resect, then you're perfectly justified in going in and taking out the tumor by whatever technique that you want to use, and then reassessing, doing the histology, assessing the histology, and then offering them post-operative chemotherapy. So here, no need for neoadjuvant, you move it to the other stage where you can offer them as a adjuvant therapy rather than a neoadjuvant therapy. But more commonly, they will be offered a chemotherapy plus radiotherapy. So you have, again, a tri-modality management offer to you where you can do surgery in a low volume disease and then offer them chemotherapy or radiotherapy. Again, all of this has to be discussed in the MDT. You cannot just decide to go ahead and operate and not have chemotherapy or radiotherapy available as a backup to you. And then, of course, we said that if no surgery is available, then the patient just goes for chemotherapy. So this is the easiest way to understand this very complicated chart. Okay, it's a very complicated chart, but once you've understood this and you go back to this chart, it suddenly starts to make sense. Okay, and that's important. So there is neoadjuvant, there is treatment, and there is adjuvant. That is what you have to understand. So neoadjuvant, treatment, and then followed by adjuvant therapy. So this is an easy way to understand what are the things. Now, chemotherapy is discussed in great detail. So let's talk a little bit about chemotherapy because we want to understand mesothelioma completely. So I'm not going to go through all of this, but what I'll tell you is the highlights of that chart. Chemotherapy alone can be offered in an inoperable patient, but good performance status, or patients who refuse surgery. We've said this before. Chemotherapy works for 3B or 4, regardless of histology. It doesn't matter, you can offer it. It may be a best supportive care for PS3 and 4, but you don't give high dose chemotherapy. You just give palliative chemotherapy, enough to keep the symptoms of the patient under control. The important thing is when you're going to give chemotherapy, this patient's pleural effusion has to be taken care of prior to chemotherapy because it has a direct correlation. The patient's symptomatic and he's got chemotherapy, he is going to do very badly. So before you give the patient chemotherapy, you must drain that pleural effusion and must offer the patient Talc. Either you can do this with a bedside drain or even better is if you can do it by VATS. I spoke about that. That is the best thing for these people. So you must sort out the pleural effusion before you offer chemotherapy for these people. Chemotherapy can be used in a multimodality treatment for medically operable MPM, the tri-modality that I spoke about, and chemotherapy can be used in other areas like peritoneal mesothelioma, in pericardial mesothelioma, or tunica vaginalis mesothelioma. Now, this is all directly from the NCCN guidelines. This is an understanding of the chart which I showed you earlier. What about trimodality? We spoke about it. Chemosurgery followed by radiotherapy, or chemosurgery with no radiotherapy. It depends. There are various studies which have looked at different outcomes. The median survival with a trimodality is about 20 to 29 months. Okay. Intra-op chemotherapy has also been studied. There's a lot of studies which have looked at, how would it be if you operate and we give chemotherapy in there, which is called as either hyperthermic pleural lavage. So you do cytoreduction and then offer hyperthermic pleural lavage, or photodynamic therapy for local pleural disease, or heated chemotherapy, which is called as HITOC. So HITOC is hyperthermic, heated, intrathoracic chemotherapy. Now, the people who do it, they talk highly about it. There is N number of papers out there and N number of centers which are selectively offering HITOC as a treatment modality. But rest assured, there is no randomized controlled trial, and there is definitely no clear-cut evidence of benefit with HITOC. So most of the people who are giving HITOC are actually giving it off the license, which means that there is really no strong evidence that it is working. But the people who are doing it are actually publishing very good numbers. The people in the US, there are about 100 centers which actually offer HITOC as a treatment for intrapleural chemotherapy for mesothelioma. So don't get me wrong. I'm not saying this is wrong. It's just that at the moment, there is no strong evidence from RCTs and things for HITOC to make it into a cancer guideline. So it is not in the guideline purely because we do not have the evidence available. And there is, again, a large number of centers who are talking about HIPEC, which is hyperthermic intraperitoneal chemotherapy. Even in India, I know at least of 3 or 4 centers who specifically offer HITOC, and I know of 3 or 4 centers who offer HITEC. This is HITEC, not HITOC. In hyperthermic intraperitoneal chemotherapy. But again, both of these are not part of guidelines because the evidence is from case control studies or personal series, not from RCTs. Okay, so what are the chemotherapy that you would give? Now, this is 3 slides. Please take it on board, write the names down. And this is 2020 evidence. Okay, so this is all the trials up to date, up to 2020. So just take down this name. And if you're ever asked what chemotherapy I will give, the level of evidence is category 1, that is cisplatinum pemetrexed. Okay, very simple. If you're ever asked what chemotherapy to give for mesothelioma, just say cisplatinum pemetrexed. That's the first FDA approved study. Very clear cut. It's got good benefits for the patient. So the name is cisplatinum pemetrexed. The other things which have been mentioned in the guidelines are bevacizumab with cisplatinum plus pemetrexed, followed by maintenance bevacizumab. So the first one was cisplatinum pemetrexed. The second one is you add bevacizumab as primary treatment and then follow it with a maintenance bevacizumab. Both of these are category 1 level of evidence, and both have got strong randomized controlled trials which have shown evidence of benefit in these groups. So get these 2 names very clear. Cisplatinum plus pemetrexed, or you add bevacizumab, and maintenance is with bevacizumab. Okay, very, very simple, nothing complicated about this. Just the names are a bit awkward to remember. There is also one more therapy where the cisplatinum has been replaced with carboplatin. Okay, so 3 therapies: cisplatinum plus pemetrexed, bevacizumab, cisplatinum plus pemetrexed, followed by maintenance bevacizumab, or bevacizumab, carboplatin, and pemetrexed. So the cisplatinum, if some patients are toxic to cisplatinum, you have the option of using carboplatin instead of cisplatinum. This is all you have to remember about chemotherapy. Don't worry about the deep names and all these big studies and all that. Just this is, in a nutshell, the 3 maintenance protocols or treatment protocols for chemotherapy for MPM. Very, very clear cut. Okay. All right. So we spoke about this. Again, I'm showing you this slide purely to clarify what we did earlier. Very, very easy, beautiful flashcard, which tells you clearly what you need to do. Okay. And again, here it's talking about cisplatinum and pemetrexed is the preferred one. And then you've got this combination, which is the thing. And then sometimes you take away the cisplatinum and put carboplatin. Okay. Don't remember all of this. Just remember the first 3 and you're winning. Okay. All right. Now, immunotherapy. There is increased studies going on immunotherapy in mesotheliomas. It's important to understand that, at least know some names. And I'm going to throw a couple of names at you just to make it easy. I won't talk too much about the studies, but it's a category 2A evidence in immunotherapy: pembrolizumab monotherapy as a single thing. But remember, immunotherapy is given as a second-line treatment, never as a first-line treatment. So you give chemotherapy and then you reassess, and if there is still evidence that the patient's got disease or he's getting symptoms or the tumor burden is still there, then you can choose to give immunotherapy to these people. And the immunotherapy agent is pembrolizumab or nivolumab with or without ipilimumab. Okay, again, now just take a shot of this screen. This is, I have really squeezed it into one shot after reading a lot of papers, trying to understand everything. These are the 3 drugs which are spoken of in the NCCN guidelines as second-line immunotherapy treatment in people who have already had pemetrexed cisplatinum treatment. And these are the ones which are showing some promise of results in prognosis of the patient. Okay, so nothing complicated. Just take the snapshot and try to remember these names, and it'll become your second nature. Okay, you have to repeat it a few times before you can say it out in the exam. So second line immunotherapy we spoke about. There is also a concept of second line chemotherapy, and pemetrexed is the one that you can give if the first time response was good and there is still some disease. You can give a second course of pemetrexed, or you can combine it with vinorelbine or gemcitabine. These are both second line chemotherapy agents, vinorelbine and gemcitabine. And I won't go into more details about the papers that are talking about this. Okay, so is that clear? Did they clarify the concepts of chemotherapy?
Yes, sir. Yes, sir.
Happy with the 3 snapshots of the drug agents? Just
Yes,
remember
sir.
the name. There's no other way, nothing else way. Just remember the names and say it out in the exam. Nobody will ask you what were the trials. There are many trials, and I can't give you the names of all the trials, otherwise you'll be confused. So I'm trying to simplify the whole thing. So NCCN guidelines very clearly talks about supportive care. Very, very strongly talks about supportive care. Not just about the pleural effusion in terms of Talc pleurodesis or pleural catheter. It also talks about smoking cessation, talks about pain management, talks about nausea, vomiting, psychosocial distress. And each one of this has a guideline attached to it. So if you ever want to look into what is the pain management, then you've got to follow the NCCN guidelines for adult cancer pain. So I won't go into I'm not going to go into details of each one of this, but just for you to understand that the supportive care is equally important in mesothelioma, because these guys are symptomatic. They usually have a lot of symptoms, and that is why you have to give them huge amount of supportive care. So what are the supportive cares? We spoke about it. pleural drain, talc pleurodesis, in medically inoperable patients, smoking cessation, pain management, nausea, vomiting, and psychosocial distress. Okay, so it's very straightforward, nothing complicated. Just in an exam, just reproduce it. And this is the flashcard for supportive care. So take care of the pleural effusion, take care of the pain, take care of any obstruction or obstructive symptoms, take care of nausea, vomiting, smoking cessation, and distress. Psychological support. The distress is psychological support. So most of these patients will have any of these, and you got to be careful. You got to take care of the patient as a whole rather than just treatment. So what is I want to talk a little bit about pleural effusion and pleural catheters. I don't know if very many people in India use this. This is used regularly in the UK. It's for people who are having palliative treatment, who repeatedly are getting admitted to the hospital with recurrent pleural effusions. You don't really want somebody who's dying or who has got less lifespan to spend the time in the hospital. So what we do is we put in this indwelling catheter. Okay, we put in the indwelling catheter under, sometimes, very often I do this under local anesthesia. So you make a subcutaneous tunnel. Through one hole, the catheter goes into the chest, and this Teflon thing lies underneath the skin, and this comes out on the chest wall, and you just stick it to the chest wall. So you put this into the pleura, you stick it to the chest wall, and whenever the patient gets symptomatic, on this end, there is a one-way valve. In fact, there are two one-way valves on this end. This comes in from the bottle. This is a bottle with a suction in it. It's prepared bottle which already has a predetermined suction in it. And so this trocar of the suction goes into this, and it pierces the valve. It pierces the first valve, then goes ahead and pierces the second valve, and then stays in. The moment it goes in, the fluid starts to flow out. The pleural fluid will flow out. As soon as you have drained adequate amount of pleural fluid, enough to make the patient asymptomatic, you just disconnect this. The moment you disconnect this valve will stop, and this whole apparatus with the catheter is thrown away. So this goes back onto the chest wall. So you can actually keep it in situ and have the patient, regularly drain the fluid depending upon how many times he needs it. Some people initially drain very often, maybe like once a month or once a week or every third day. And then gradually with time, because you're gradually draining the fluid, the lung also starts to expand a little bit, and the amount of fluid goes down with time. And eventually the lung will actually reach the chest wall, and there will be some sort of pleurodesis. And then you can take the drain away. You can take the catheter away. Or some of the patients even die with the catheter in situ. So it just makes the patient's life very comfortable, and he doesn't have to spend repeated admissions within the hospital. Also, when we are giving people chemotherapy, presence of a pleurax drain makes it very easy for the treating clinician to actually control the pleural effusion. But remember, when you give chemotherapy, there is a risk of infection and empyema, particularly because of a foreign body present within the chest. So be careful when you're using a pleurax drain in a patient who's about to undergo chemotherapy. You've got to be very careful. In the UK, we admit the patient, we get the patient in for daycare, we put in the pleurax drain, stick it here and send him home. We have district nurses who will reach out to the patient. Initially, they visit their home a few times with these bottles, and they teach the patient how to use it. And then after a little while, the patient does it himself. And very often these patients come to my OPD. I've got hundreds of them in the follow-up who come to the OPD, and they give you a graphic representation they really love writing down how much fluid came out and things like that. And then if you've got to take the drain out, it's very easy. All you have to do is just give some local anesthesia, make a slight incision around this 2 or 3 millimeter mark, and then just pull the drain out. The one thing you got to remember is the Teflon thing sometimes forms the fibrosis in the subcutaneous tunnel. So you got to dissect that out before you pull it out. But most of the time, it'll just come out by yanking it out. It's quite easy way to do it. Okay, so that's one concept. So we've spoken about chemotherapy. we've spoken about palliative care. We've spoken about use of a pleural X-ray. Now let's talk about surgery, because really this is what we all want to know. What is the surgery that is possible in mesothelioma? Okay, guys, so far so good. Is it clear?
Yes, sir.
Yes, sir.
Yes, sir.
Yes,
Okay.
sir.
All right.
Yes.
So let's look at surgery. So what do we do in the surgical world with mesotheliomas? Okay. So we operate only in the early stages, stage 1 to
Yes,
3A,
sir.
only if the patient is medically operable. Always important to do a PFT with DLCO, mandatory. And we have understood from the PFT lectures
Yes,
what
sir.
is the importance of DLCO. We do perfusion scanning if the FEV1 is less than 80, because we really want to know what is the underlying lung capacity of this patient. Always cardiac stress test is mentioned. And as I said again and again, I'm saying it's got to be multimodality treatment, never surgery alone. Now, this is from the guidelines, okay, from the NCCN guidelines. So you can quote this to the examiner, what you do in a surgical staging. The most important thing is not everybody should operate on mesothelioma. You must be a specialist mesothelioma surgeon, because these are complex surgeries. You really need to be experienced to know how to do a EPP or how to do a PD. It's not a straightforward surgery. You really need to know what you're doing. You start off with the VATS biopsy. That's what you do because you want to know the diagnosis. But when you do the VATS incision for the biopsy, make sure you take an incision along the expected thoracotomy line. These are not done by VATS, the final surgery. It's done by an open thoracotomy. So try to keep your VATS incision along the line of the thoracotomy that you're going to do the second time. Okay. The surgeries that are available for you are pleurectomy, decortication, which is a total pleurectomy, lung sparing surgery, but you must also do nodal dissection. Okay, you must sample nodes. The other surgery is extra pleural pneumonectomy. Again, you must sample nodes. Okay, removal of the lung, but includes the ipsilateral diaphragm and pericardium. That is an extra pleural pneumonectomy. Extended pleural decortication, there is something called as extended PD, where not just taking out the pleura, but you're also taking out diaphragm and pericardium. You leave the lung behind. So in PD, you leave the lung behind, but peel it all off, including the visceral pleura, the parietal pleura, the diaphragmatic pleura, and the mediastinal pleura. If you're going to do an extended PD, you've got to take out the diaphragm with it, and you got to take out the pericardium with it and then reconstruct. So I'll show you diagrams, don't worry about it if you haven't understood it now. Mediastinal nodal dissection is recommended for mesothelioma surgery. The minimum is 3 stations. So at least 3 stations you must sample, because you need to know what is the exact histology and what is the exact staging of this patient. The aim is cytoreductive surgery, but all macroscopic tumors should be removed. So you must do what is called as macroscopic R0. You cannot leave tumor behind. That is not acceptable. That is against the norms of surgery, of mesothelioma surgery. So when you are got into a chest and you found that there's multiple chest wall invasions at multiple sites, you must abort the surgery. You cannot do an R1 or an R2, macroscopic R1 and an R2 surgery. If there is a single site of chest wall invasion, then you can take it out along with the muscle and the ribs that you need to. But you cannot do multiple chest wall invasion. So when you get in there, always the surgery is decided after you've got into the chest. So it's never decided before. You have to go in there, see exactly how much is the pathology, and then decide whether you want to operate or not. Okay. The important thing to remember is that you never get microscopic R0. So don't be under the illusion that you're taking away the cancer. That is really important. You must know that no matter what you're doing, it is always microscopic R0. Extended pneumonectomy has higher morbidity and mortality. So extrapleural pneumonectomy definitely has higher morbidity and mortality than PD. In fact, nowadays, very few people actually do EPP. Most people, or most of the mesothelioma surgeons, will do an extended pleurectomy decortication. Again, the survival with extended pleurectomy decortication is more than extrapleural pneumonectomy, because the complications of extrapleural pneumonectomy are much higher, and most of these patients die because of the complications rather than the disease itself. So it's not a walk in the park. It's quite a difficult operation. You got to very carefully before you start doing these operations. And but the problem is that there is not enough evidence at the moment to say that pleurectomy decortication is oncologically superior than EPP. That's the problem. So, you know, where do you balance it out? You don't know the outcomes of the two surgeries just as yet. And intraoperative adjuvant therapy, which I spoke about, the high pack and high talc, if you ever do it, then it should all be part of clinical trial. Should never be as a standalone treatment. So if you're doing it within the context of a clinical trial, it's accepted to do high pack, high talc. But if you're not, if you're offering high talc as a treatment for the patient, then you have very little evidence to support your clinical practice. MAS trial, everybody talks about MAS trial. MAS trial was a trial which got published, I think, around 2012. They recruited patients. The trial was looking at induction chemotherapy followed by extrapleural pneumonectomy. And the problem with this trial was, A, the recruitment was very low, and there was seriously high rate of surgical mortality by EPP. So much so that they had to actually stop the trial because of the high rate of surgical mortality. But the controversies of MAS, people who discuss MAS in more detail, there are 2 or 3 factors which are important. MAS was never designed to look at survival. It was designed to look at the efficacy of chemotherapy followed by EPP or chemotherapy alone, or EPP alone. And survival was never the endpoint. So really, to make any clinical sense or any scientific sense out of the data is a bit difficult. The sample size was pretty small, very, not enough patients were recruited within the 2 arms. And more importantly, the surgical mortality that we saw in MARS was higher than the expected mortality. So there is a certain mortality you quote for EPP. The surgical mortality was definitely higher. So the question was, had it got to do with the surgical skills of the surgeons who were taking part in the trial? So these are the points which are frequently discussed about MARS trial. We know that PD is safer than EPP, but not clear if it's oncologically superior. PD is more appropriate for patients who cannot tolerate EPP. So it is a better tolerated operation. It's good for symptom control. PD is pretty good, particularly when there's entrapped lung or the patient is having recurrent pleural effusion. Then doing a pleurectomy decortication allows the lung to re-expand and fill up the space. But post-operative, it really takes a lot of effort to stop the air leak and things like that. These are very complex operations with complex post-operative management. There is no surgery for stage 3B4 regardless of histology. No surgery. Do not offer surgery in stage 3B or 4. And if you've got N2 disease, do not offer surgery. You have no justification for operating on a patient with a mesothelioma who's got N2 disease. That is why you need to be in an MDT, because very often the mesothelioma surgeons are very aggressive and they want to get on with and operate on everything that comes their way. But the moment this goes through a MDT, the MDT will stop the surgeon from operating and send the patient for chemotherapy. So N2 is not recommended for surgery in mesothelioma, okay? So let's look at the various operations and see how it is. This is how you do this is the incision. This is no VATS surgery. There are some papers now which has come up with VATS pleurectomy decortication for mesothelioma. But honestly, you can never get the same extent of R0 resection. And I don't think VATS adds any value in this operation. It's a very, very big operation. And you got to do a huge thoracotomy. You got to do a whole extrapleural dissection, completely put your hand and take all of the parietal pleura off. And the difficult part is when you're taking the thoracic outlet off. That is very difficult because it is stuck. It's almost like aspergilloma surgery. And B, when you're taking the mediastinal pleura off, particularly over the SVC on the right side. So when you're trying to dissect between the SVC and the pleura, it's a harrowing time, and there's a high risk that you might end up into the SVC and cause a bleed. So you got to be very, very careful. So that area and lower down when you come to the diaphragm again, but if you're doing an extended PD, then you take away the whole of the diaphragm. So that's all right. There you don't have to dissect, but the real harrowing moment is when you're dissecting off the SVC on the right side, and on the left side you have to take it off the descending aorta and the arch of aorta. So there is a risk of injury to these major vascular structures. And of course, not to talk about the nerves, because you can hardly see them in all of this fibrosis. And that is why if you've done a talc pleurectomy, the dissection becomes easier because the visceral and parietal pleura is stuck, and then you can peel it off the lung pretty smoothly. So this is the lung and this is the cortex, just like doing a decortication for tuberculosis, but 10 times more problematic because the tumor is sometimes going across the visceral pleura into the lung, because that is stage 2, and even T2 tumors can be operated by PD. So you really got to aggressively take out all of that pleura. And then when you get into the diaphragm, you've got to cut across the diaphragm. You've got to cut all the muscles, leaving a rim on the edge for reconstruction. So you really take out predominantly all of the diaphragm. And when you're doing diaphragm, you use a harmonic diathermy rather than normal diathermy, because the muscles twitch a lot. So harmonic helps you to cut across these muscles. And then you have to reconstruct the diaphragm with whatever you've got. You can use Gore-Tex, you can use PTFE, whatever patch is available. You reconstruct the diaphragm, and then you come medially, and you have to take out all of the pericardium. So after reconstructing the diaphragm like this, you've got to come in and take out all of the pericardium. That leaves a large gap on the heart, and then you've got to reconstruct the heart, the pericardium, with multiple fenestrations on the material to make sure that you do not cause a cardiac tamponade. So these are big operations, 6 to 8 hours procedures, nothing less than that, because you really have to get in all around. On the right side, particularly when you're taking off the diaphragm, you got to be very careful that you do not damage the IVC, because IVC comes through the diaphragm, and you've got liver in your way. And if you have damaged the IVC, it is very difficult to get control, because the lower liver is down and you've still not done the medial dissection. So it's very, very important to be careful when you're taking the diaphragm off on the right side. On the left side, you're relatively okay. Extrapleural pneumonectomy starts with all of this. You do the extrapleural dissection, go behind the esophagus on the right side, and you're taking away all the adhesions. And then you get the superior pulmonary vein and the inferior pulmonary vein. You tie it off, and then you get the bronchus. This is extrapleural. You're outside the pleura. You're actually taking away the lung along with the pleura that is covering, and then the whole of the diaphragm is incised. You make a semicircular incision. Here is a rim that is left behind, because that is where you will suture the patch onto it, and you've got to cut it all across, take away all of that diaphragm. You got to come in medially and take away all of the pericardium on your side, whether it's the right side or the left side, depends on that. And then the whole specimen is delivered out. As I said, the SVC is a real problem, and getting into the hilar structures outside the pleura, you really need to know the anatomy, and you need to know exactly where you're getting at. You don't have control of these vessels, and if you get bleeding, then you're in deep trouble. So you really need to make sure that the pericardium is open, and you can get intrapericardial control if you've got bleeding. There is no other way you can get control. If you ever cause bleeding in an extrapleural pneumonectomy, you will never get control. And in addition to that, you're also taking away part of the chest wall. Whatever is involved, you've got to resect all of that chest wall. So it's a very morbid operation with great morbidity post-operatively, superhuman amount of issues. Patients, you really need to manage them post-operatively, and patients don't tolerate this. And the problem is that you do all of this knowing that you're leaving microscopic tumor behind. That is the problem, because not only do you have to do this operation, but you've got to follow it up with chemotherapy or with radiotherapy. So it's very important to really assess this patient before, to make sure that he'll be fit enough for a large surgery, a large amount of chemotherapy, and a large amount of radiotherapy. So it's no walk in the park for these patients, okay? And then you recreate the diaphragm as we showed earlier, and then recreate the pericardium and close the whole thing out. So we've done chemotherapy, we've done surgery, okay? We've done supportive measure. Now the only thing left behind is radiotherapy. Let's quickly look at radiotherapy. Again, these are the guidelines for radiotherapy, very complex to read into. So let me simplify them for you. Radiotherapy alone is not recommended. It should always be part of multimodality therapy. It's good for palliative treatment for chest wall pain, for bronchial obstruction, or for esophageal obstruction. So we do use radiotherapy when the patient is symptomatic, because using the radiotherapy, you can actually reduce the tumor burden of that particular area and reduce either the pain or the breathing or the dysphagia. So it's important. It's a good tool for palliative treatment for symptom control. And again, you can use it for bone or brain, depending upon wherever there are metastases which are giving rise to pain. You can use radiotherapy as a modality for treatment. Dose of radiation depends on the purpose that you're using it for, okay? So the timing of radiotherapy has to be multidisciplinary. You've got to decide when surgery, when radiotherapy, and things like that. After EPP, adjuvant radiotherapy, there is evidence that adjuvant radiotherapy decreases recurrence. So the microscopic cells are taken care of rather than just the surgery. But the important thing, previously we were taught, and we used to do it as well, that you know, when we have done a VATS biopsy or things like that, we used to give radiotherapy to the surgical ports to prevent the tumor growing through the surgical port and causing subcutaneous nodules. But the 2000 guidelines have looked at all the literatures. Particularly, there was a trial called a SMART trial, and they said that there is no routine prophylactically radiotherapy to the ports after pleural intervention. This is a new change. This is not the practice that we were doing. We used to routinely give radiotherapy to the VATS ports after surgery. But the new guideline is saying there is no routine prophylactic radiotherapy. There is no benefit, or the benefit is not adequate to support its use in a guideline. So be careful when you're giving radiotherapy to the chest wall. It is actually not supported by the SMART trial, okay? Then these are the various types of radiotherapies that you can use. We have said that for limited disease, no resection, high dose radiotherapy is not recommended. So you cannot say that, you know, there's a little bit of disease, but he's not fit for surgery, let me give radiotherapy, because radiotherapy carries significant toxicity and there's no improvement in survival. So there is no benefit of giving radiotherapy to a limited disease, even though the patient is not fit for surgery. So remember this is very often the radiation oncologists will try to push their way and try to give that. It is not supported in the NCCN guidelines. So do not allow them to give radiotherapy to a localized disease. The radiotherapy can be used in the form of IMRT. You can use all these techniques to decide how to do IMRT. You can do a CT simulation planning. But the most important thing is the volume should be discussed with thoracic surgeon. Whenever my patient who has undergone surgery goes for radiotherapy, I go down to the radiation room and I sit for 1 or 2 hours with the simulation planning radio CT scans, and I decide along with the radiation oncologist what is the area to be covered by radiotherapy. It's very, very important that the thoracic surgeon is involved in planning the radiotherapy. And you must go all the way up to your clips. So when I operate on the patient, I usually leave clips behind to guide the radiotherapist up to the margins of radiotherapy that he needs to give. Particularly, I will mark out the sites where I'm worried that the tumor has gone beyond into the chest wall. So though I'm doing a macroscopic R0 resection, I know some areas are looking suspicious. I will put surgical clips. And when this patient comes back for radiotherapy, I go down into the radiation oncology department and I identify what is the area that we need to cover. The total volume of radiotherapy is 45 to 60 gray, but you have to give it in increments of 1.8 to 2 gray per day. So one more part of the guidelines is talking about how much is the volume. So this is IMRT. These are the specialized techniques available now. These are modern techniques of CT. You have to use the ASTRO guidelines whenever you use radiotherapy. And the newer techniques are image-guided radiotherapy, helical tomotherapy, stereotactic radiosurgery, SBRT. The philosophy is to minimize radiotherapy injury to the contralateral lung. And that's why these new techniques have come into being to reduce the radiation risk to the other lung. So this is the last, one of the last slides. So you've got to look at what is the dose of radiation. So there are various doses depending on what is the situation. So let's just quickly talk about it. A normal dose of radiotherapy is 45 to 60, maximum is 60, given in 1.8 to 2 grays per day. Minimum dose should be 40. So you should not go below 40, otherwise you will not get benefit of the radiotherapy. It is important within the dose that you cover the surgical bed, the surgical scar, and the biopsy tracks. This is for therapeutic radiotherapy. We are not talking about palliative radiotherapy to the VATS spots. This is when you're giving radiotherapy as a treatment modality. Then the thoracic surgeon has to sit down and decide what is the surgical bed, where are the surgical scars, and he's got to point it out to the radiotherapist. When you're giving it for chest wall pain, you can give a higher dose. So you can, here you're giving 1.8 to 2 grays, but for chest wall pain, it's an acute treatment. You really want the tumor to go down. You can give almost up to 4 grays per day to reduce the tumor mass quickly so that the pain comes under control. There is some role of use of brachytherapy and intraoperative beam therapy. This is all in trials at the moment, and nobody knows whether it is worth calling in the radiation oncologist into the operating theater to give intraoperative beam therapy. So what are the poor? We've done all of this. We've done chemotherapy, surgery, radiation. What is the prognosis of this patient? Is he going to live or is he not going to live? So let's look at some prognostic factors. So male gender, sarcomatous histology, presence of chest pain, which is shortness of breath and chest pain, poor performance status, weight loss, and increased age are all poor factors. They are poor prognostic factors. If the patient has any of this, there is high chance that your treatment is not going to help the patient. That is the most important. That is why you got to be very careful when you select these patients for surgery. You really need to work them up very well. There are some blood factors which they have looked at. These are all single individual papers which have looked at individual blood factors which may be associated with poor prognosis, but these are not as yet ratified by RCTs. But if somebody asks you, you must remember that plasma LDH and platelet count and WBC and anemia, these are common sense things which are associated with poor prognostic factors. So what actually is the prognosis of these patients? That's the question. That's the main thing that you want to ask. Now, after treatment, the current evidence is showing that 40% of them may be alive at 1 year. 20% of them may be alive at 2 years. 10% of them may be alive at 3 years. And none of them are alive at 5 years. The number that you've got here, 40%, sounds acceptable. But the other side of this is you've got to realize what is the quality of life that you're offering to these patients. That is the most important thing, because Imagine having extrapleural pneumonectomy, then having a full dose chemotherapy, then having a real whopping dose of 60 gray radiotherapy. What is the quality of life that you will offer to this patient? And that is, we don't have an answer to that as yet. And that is why the treatment of mesothelioma is so complex and it's so difficult to choose the correct patient. Most of us will offer all of these to a young, fit patient who has been incidentally diagnosed and particularly who's got limited disease. These are the guys whom we offer this tri-modality treatment. The trials have not really come out with a definitive answer. At VATS, they are in the process. They've done about 300 plus cases. David Waller is going to be publishing his results, and we are hoping that his work will add to the volume of work and help the NCCN guidelines decide what the treatment should be in future. But at the moment, the mean survival is only 8 to 14 months. I mean, the question you have to ask is, the guy would have anyways lived only 6 months, 5 to 6 months. And if all these treatments, after all these treatments, he's going to live 8 to 14 months, and with what quality of life, really, are you justified in doing this treatment? And that answer can only be given by an MDT. Most important, that answer can only be given by an MDT and a fully informed patient. The patient has to be fully informed and he has to take the decision. But overall suggestion is that epithelioid has better survival than sarcomatoid. The moment the diagnosis comes back as sarcomatoid, most of us go into the palliative regime and get into talc pleurodesis or pleuroextrain. So it's a very complex disease. It has got severe symptoms for the amount of tumor load. It's not easy for the patient. Chest pain is very difficult to manage. The treatment modality available is a tri-modality treatment. Palliative treatment at the moment is the main treatment that most of us offer for these patients because they're usually diagnosed pretty late with extensive disease, and overall the prognosis is not so great for these patients. Thank you. Okay. All right, so that was a huge long input into mesothelioma. Okay, come on.
Thank
now
you, sir.
I'm very happy to take questions. We are almost at 2 hours, so that's been a huge thing. Okay, 2 hours. Let's go. Questions. Do you want me to read the questions from the group? Let me just have a quick look. Give me 1 second. Okay. Hang on. Let me just escape my. Stop this PowerPoint. Somebody wants to ask me. You can go ahead and ask me. Start asking me.
This is Dr.
I'll
Faiz.
Dr. Harish, how are you?
I also have a question.
Who is that? Shilpa. Start off.
Yeah. Can I start, sir?
Yeah, start. You sound as if you got coronavirus.
Okay.
Don't
Sir,
be down.
Okay. Okay.
Yeah.
So in MAS trial, you've said that survival was never an endpoint for pleurectomy decortication over an EPP. But at the end of the slide, at the end of the presentation, we have seen that survival is definitely less. So if in exam, we land up, if they ask, what kind of surgery will you offer in an operable patient? What do we say, an EPP or a PD?
Extended PD. The safest answer is extended PD.
Okay.
Don't talk about EPP in the current scenario.
MAS 2.
Yeah. There are a lot of trials.
So MAS 2.
Shilpa, there are a lot
MAS
of
2
trials
trial
going
is going
on
to.
at the moment. Listen to me. There are a lot of trials going on at the moment, and they haven't been published. I have given you hot of the press 2020 guidelines. There's nothing more than this, nothing less than this. If you know up to this point, you're absolutely okay. Nobody is going to ask you about future trials because you are not supposed to know about MARS 2 till it's published. You understand that? And Plymouth, Derriford is not a center for the MARS trial. So you don't have to worry about it. So they really genuinely in an FRCS exam will not expect you to know about ongoing trials. You're never supposed to know about it. Only you can say there is a name called as Mars 2, but we don't even know what is the recruitment criteria for Mars. Unless and until you're involved, your center is involved, there is no way you will know this information. Okay, so don't worry about it. Just whatever I've told you, all the slides that I've told you, these are the important factors, and this is really up to date. So don't worry about it. Okay. All right. Somebody else now. Let me look at the questions.
Thank
Very
you.
happy to talk.
Yeah. Who's next?
Here, I'm Dr. Faizul from Dhaka.
Hi, Dr. Faizul. How are you? What's a
Assalamu
pediatric?
alaikum.
Walaikum assalam.
Yes.
What's a pediatric cardiac surgeon doing on mesothelioma surgery? My God.
I was happy to hear it. I got time. So still, thank you very much. I had a very
Thank you,
attentive attention
Thank you, sir. Tell me.
to all
Ask the
the
question.
words. And I was looking forward to. So what should be the focus on the natural history of the patients to counsel and to focus, because we see that the outcome surgical, or it's a multimodality answer, and the RCTs and the trials are going on still and not very encouraging, though we can offer.
No, trials are, it's not that it's not very encouraging. In the UK, because we have so many patients, we are offering them surgery. It doesn't mean that we are not offering them surgery. We are offering them surgery. The current, because I work in a center where we do mesothelioma. So I am seeing some good outcomes in people. I'm surprised myself. So I think this chapter is not yet closed. I think there is more data to come. The guidelines cannot accept data unless it is ratified with good evidence. So I think Mars 2 is important. The other trials are still going on. But at the moment, if you had to ask, give me an answer, I would say chemotherapy is the gold standard at the moment. Palliative treatment is the gold standard. Somebody's music is playing, guys.
Yeah, Dr. Ali, can we get them to mute it?
Yeah, mute your good music, but I can't think. Okay, so palliative care is very important for us surgeons. We offer palliative care. If you have to do surgery, then it is only in specialized centers. In the UK, there are only 4 centers which do it. So it is very, very specialized. But nowadays, patients are asking for surgery. Remember, no matter what you do, the patients are asking for surgical intervention. And no MDT can stop it. If the patient says he wants to have treatment, if he's a young guy, 35-year-old guy who came in with pleural effusion, you went in, did a pleural biopsy, the diagnosis came back as mesothelioma, the patient is not going to say, I'm only got 6 months to live, let me die. He wants treatment. So he looks at, 3-year, 4-year treatment. So these people come up and they push you for surgery. But you must always make sure that you don't do surgery alone. You offer them chemotherapy and radiotherapy. Okay. That's the message.
Right.
There's nothing wrong with doing surgery. It's a complex thing, but you have to select your patients very carefully.
Thank you, sir. Thank you.
Okay, sir. Thank you very much. And good to see you. Good to see you. Hope everything is okay.
Yes, sir. All the best.
Thank you, sir.
And
next question.
I hope everybody in the world have a safe time from COVID-19 as well.
I hope so too, sir. I hope so too. Next
Hi,
question,
Dr.
sir.
Ali, Harish here.
Hey, how are you? So
how are you? I'm good. I'm good. I love the aura behind
Singapore,
you.
my man. Tell me.
So, it's 2 o'clock in the morning here. I've been listening to your talk. It's amazing. I had 20 questions, but now it's down to 2. So the first thing it's that I always wanted to ask is that we've always encountered epithelioid mixed. I know sarcomatid has a bad prognosis, so we don't operate on them. But what about the mixed category of people?
Yeah, if there is a mixed category, then you really have to assess the patient very carefully. Epithelioid, we are very happy to operate. But if it's a mixed and he's a young guy with very little symptoms and it's an incidental diagnosis, you cannot deny this guy's surgery because it is mixed. You understand that? So that is why the mixed category, we still offer surgery, but much less than usual, much less than usual. Because the sarcomatoid part of that mix will cause recurrence. That's the problem. But if it's a fit guy, then you have to consider him for treatment.
Okay, so my second question is that we talked about microscopic and macroscopic resection.
Indeed.
And a lot of times we encounter, so we've been doing a lot of PDs, peritoneal decortication, pleural decortication. And the issue is that, at the costophrenic junctions, especially when you're trying to resect the diaphragm, there's always some bit of tumor behind there and you can pluck it out, but you're never going to get R0 or even R1, macroscopic resection. So, what happens to those patients? Like, do you think we're actually doing them any justification? Because, and the other thing I always have a big problem is dealing with the fissures, because when we get into the fissure and you're doing a decortication in the fissure, you can never go all the way down to the pulmonary artery. It's very, very tricky over there. So.
Yeah, I see. This is a very difficult question because in your heart you have to be convinced that you're doing the right thing for the patient. Very, very often we come out of the theater and think, "Shit, we left things behind." And if you have, then you hope and pray that the chemotherapy takes care of it or the radiotherapy takes care of it. But theoretically, if you look at the literature, the outcomes work best when you haven't left behind disease. It's all about what is the outcome. So even within your operated group, there is a certain group who gets recurrence, and there is a certain group who doesn't do well with surgeries. These are the ones who don't do well with surgeries because you have actually not got into that costophrenic junction and taken it all out, or you've not really cleared all of the interfissural area. The reality is that, honestly, hand on heart, you are not doing R0.
Yeah, absolutely.
That's the reality. No matter
yeah.
what you say. If you ask David Waller, he will say, no, I do R0. I have scrubbed in many, many, many times with David Waller. Promise you it's not R0. So that is why this, it's a very big surgery to undergo for how much gain is the question that you have to ask yourself. And I don't think we have answered that as yet. That is why we need more studies before we can say that mesothelioma is a curable disease. Most of the times, 95% of the times, you will end up into a palliative domain. It's only, a small number of patients whom you really go down the surgical route. But hands on heart, as a thoracic surgeon, you've left things behind.
Right.
That's the reality, Harish.
My last question actually is, and I'll put it up on the group chat tomorrow morning when I load up the scans. Very interesting case. It ended up becoming a solitary mesothelioma, a solitary lesion that looked like a chest wall lesion. And we resected the ribs and took out the tumor, took a bit of diaphragm, took a bit of lung, and it was a solitary mesothelioma. And the rest of the biopsy from the pleura was negative. Okay. So any comments on what we should do? Because I went online and I looked up for, case, there's only about case studies about it. It's one patient, like one study, but that's it. So what do you recommend? Continue with chemo after that and RT to that localized area?
I think so. At this stage, yeah.
Yeah, so that's an interesting case. I'll put it up on the group chat.
Yeah, please do that. I'd love to see the CT scans. And if you want, I can discuss it in my MDT. And then we'll see what we can, bring back to you. But so good to see you, Harish. Good to see you.
Yeah, great to see you. We'll catch up again in 6 months. When
we need you to lecture on this forum, my dear friend. I still see through your chest wall presentation. Fantastic. Yeah. Well done.
Happy to do it again, sir. All right.
Please do it. Please do it.
Have a good night. Bye-bye.
Thanks. Good night. Next question, please.
Sir, Amol here, sir.
Yeah, Amol, tell me.
Sir, thanks for the extensive coverage, sir. It was wonderful. Up to date. Sir, as younger surgeons, we don't have much to do in this. But for all those who are exam going, I would like to ask some questions. Sir, are there any biomarkers which can be used for follow-up of the cases?
No, the biomarkers, they are used, the SMRP is used for follow-up.
Yes, sir.
At the moment, SMRP is the only one which is used for follow-up. The other ones are still under investigations.
Okay, sir.
They are actually claiming, some of those are claiming, I forget the other one, the mesothelin test is claiming that it can be used as a marker for follow-up. But the evidence is not clear at the moment. But SMRP is the one that can be used, yeah.
Okay, sir. Sir, what can be done for tract metastasis? If they ask in exam, they might ask in exam what you want to do for tract metastasis where the chest tube was put or something like that.
Yeah, in the old days, we used to give radiotherapy to it. We could do local resection and things like that. If it is symptomatic and it's causing patient pain, then local radiotherapy is an
Yes, sir.
answer for the pain, but you're not taking away the tumor. Once you've got tumor coming
Yeah.
out, you're in T4 zone. And so you're really not doing much favor to this patient. But the
Yes, sir.
answer is, you can't really do another local resection because that will just add to the problem. So local radiotherapy should be the answer in the exam.
Okay, sir. Sir,
But remember, the guidelines have changed that.
yes, sir.
Prophylactic radiotherapy to the ports is not recommended in the guidelines. You give radiotherapy when the problem happens for pain control.
Yes, sir.
Okay.
Sir, in exams, they discuss a lot of CT scans and all. So if they
Yes,
put up
they
a
do.
CT where focal pleural mass which is invading into the pulmonary parenchyma, if they ask us, what do you think, whether it is a primarily a pleural mass going into lung parenchyma or a CA lung which is invading into a chest, can we differentiate these two scenarios, sir?
Only if it's a localized mass, you can on a CT, but just on just mesothelioma will show you other signs elsewhere. And there is something called as push and pull of a mass. So if a mass, there are some push and pull signs. So if a mass shows push signs, then it is a pleural mass. If a mass shows pull signs, it is a lung mass going to the chest wall. I'll have to do a class on CT scan to show you all these.
Yes, sir.
I'm happy to do
Thank
a class
you,
on CT scans.
Sir, that
Yes,
will
sir.
be really helpful if you do it.
Okay, we'll do that next time. Not next time, but sometime.
Okay.
Yeah. Okay, what else?
Thank you, sir.
Okay, thank you very much. Is everybody happy?
So one question,
One more question. Who is that?
Bhushan.
Bhushan. Tell me, Bhushan, how are you doing? I haven't seen you for a long time.
Very elaborative and concise and very made easy, made to look easy.
2
Yeah.
hours, it can't be easy, man. Tell me.
I think you are studying more harder than us.
Okay, tell me, Bhushan. Ask
Sir,
the question.
experience about plastic mesothelioma.
Sorry?
Desmoplastic mesothelioma. We came across a patient, 70-year-old, performance status around 2. He had underwent biopsy 2 times by VATS, failed, and we had to do a open biopsy. And intraop it came. His PET scan was also negative. The lung or no nodules anywhere else. But now the pathologist has called up and told that it has an desmoplastic mesothelioma. And the lung is not expanded, the chest is contracted, although the chest pain has reduced and the pleural effusion is still draining.
It's a very difficult situation. One thing I can tell you for sure, he's not a candidate for surgery. He's a candidate for palliative management. In palliative management, first thing I would do is I would take the chest tube out and I'd put in a Pleurex drain. That's the first thing you have to do. You have to take away the chest tube and put in a Pleurex drain and then send him for some palliative chemotherapy. Okay. The reason why you give palliative chemotherapy is just to get symptom control, not to get disease control, but to get symptom control. And a little bit of chemotherapy will actually reduce the inflammation around there. And this guy hasn't got a good prognosis. He hasn't got a long life to live. So make sure that you get symptom control.
I checked along all anecdotal reports. They were saying that 7 to 8 months lifespan on an average.
Probably less. But anyway, he's not got much life to live. And 72 years old will not do well with all these treatments. So symptom control, put in a IPC, send him home. Intrapleural catheter. IPC means intrapleural catheter. Send him home. Even if you haven't got a Pleurex drain, I think there is an Indian version available. So I don't remember the name of the company. When it comes to me, I'll tell you.
Yeah, Indian version is available. Yeah.
There is an Indian version of that, I see.
Mhm.
Okay, next question, guys.
Sir, another question, sir. Rishabh here.
By the way, yeah, hi, who was that? Rishabh Kapoor. Yeah, one minute,
Yes, sir.
Rishabh. Just one comment, Rishabh, before I. By the way, this is the third day on the trot that we are full house, okay? Even on the YouTube. So well done to thoracic surgery. Rishabh.
Thank you, sir.
Yes, good evening, sir. So thanks for
Hi, good
the
evening.
extensive, coverage of the topic. Sir, you mentioned this mean median life period of 18 to 14 months after the treatment, extensive treatment that you've given, multimodality treatment. So your patients, have you seen them living more than that, or it's still that?
Yeah. They do. Some of them live more than that as well. But that is because we are in a specialized center.
All right. Thank you.
Yeah, it's got to be specialized mesothelioma center. If you are doing one surgery every 2 years, chances are your patient will die on the table. Not an easy surgery. It's a very complex surgery.
Okay. Yeah. Thank you, sir.
Yeah. Okay. Thanks. Next.
Hi, sir. Good evening. This is Dr. Ramasamy, sir.
Hi, Dr. Ramasamy. How are you? Very handsome
Fine.
picture you've got.
Fine, sir. Thank you. Thank you, sir. How are you?
I like your
Sir,
profile picture.
Thank you, sir. Thank you.
Tell me.
Sir, two questions, sir. Preferred mode of biopsy is VATS. When we don't get space to put ports, can open biopsy be done?
Open biopsy is okay.
And what is the recommended length of the incision, sir? And preferred is on the thoracotomy line, but what is the recommended length of the incision?
There is no recommended length. Usually 11 mm to get in a 10 mm port and an instrument next to it.
For the thoracotomy, I mean open biopsy, sir.
Open biopsy is 1 to 2 centimeters. 2 centimeters is all you need. You don't need to do more than that.
Okay. Right.
It's just like doing a thoracotomy, but to a narrow space. So you don't do a big incision. You try to keep it as small as possible. Because if the diagnosis comes back as mesothelioma, the last thing you want is tumor going through your incision. So try to keep it as small. Whatever is your comfort zone, you can increase it. You can always increase a 2 centimeter to 3 centimeter, but you cannot decrease a 3 centimeter to 2.
Yes.
So that's why I start small and then increase according to the convenience that is there. People do open biopsies, yeah.
Okay, right.
But the problem with open biopsy is you are only getting one area that is below your incision. Whereas with VATS, you will get more than one biopsy. That biopsy that you get may not be representative, so you'll miss the disease. That is the worry.
Yes.
Okay, 2 people raised hands. Who raised hands? Let me see who raised hands. Itun, did you raise your hand?
Yes, sir.
Okay.
One question. There is the old-fashioned Abraham needle for taking pleural biopsy. Does that have any role anymore, or?
No. You can do all those things, but really, tissue is the issue here. It's not an easy diagnosis. I mean, look, Bhushan said they have done VATS 2 times and not got the histology answer. So it's not an easy diagnosis. People don't do needle biopsies anymore.
Okay.
All right.
Doctor, sorry, I know I asked the question earlier, but this is such a
Hey, hi, how are you, Harish?
We've had scenarios where the lung looks collapsed and trapped by the mesothelioma, and there's got a lot of pleural effusion. And we feel that sometimes the lung can expand. And so would you recommend, if you put a scope in, you drain everything out, and then you biopsy it, and you're pretty sure it's mesothelioma, would you recommend, because the lung is completely trapped by the whole tumor, right? Do you think that we could even do a decort to just expand a little bit? I mean, we're not buying him any time anyway. So probably Pleurex catheter, like you mentioned, and come out. That's it.
No, I don't think there is any role for a decortication in that situation. There are only 2 things. One is if you think the lung is going to re-expand, then trust your medulla. So I put in talc. There are many times where on table I have not got full expansion, but I feel that the lung may expand. I put in talc, I put in a drain and connect to medulla so that I actively allow the lung to expand. And the second thing is with Pleurex drain, if you put in a Pleurex drain, the natural history of CT scans or chest x-ray shows that with a gradual intermittent drainage, the lung actually expands over a period of time. So much so that it causes pleurodesis of the space. So there is a definite reduction of space seen with patients who have pleuric strain, to a point where you are able to take it out actually. So I would not do a decortication. If I'm going to do something, then either it's part of a, for symptom control in mesothelioma, decortication has really very limited role, because you'll end up with an air leak, and that is even worse.
Yeah, absolutely. It's just heroic work.
Yeah, it's heroic actually. So I would actually, if I believe that the lung, if I believe that the lung is going to come up, I use Medela. And then 2 days later, if Medela is not working, go in and put a Pleurex drain under local and just call it a day. But it's worth giving it a try with Medela.
That's a great input. Thank you very much again.
Yeah. Thanks, Harish. 2 o'clock, man, go to sleep. I must be saying something interesting to keep you up, huh?
Oh, it was. I stayed up for this talk, so that's why.
All right. Thanks. Okay. Who else wants to ask questions? Come on, guys. 2 hours, 15 minutes. Come on, quickly.
So I want to ask one last question.
Yes, Silpa, you have to have the last
So I want to
word.
ask one last question.
You're the lady in the room.
Yeah. Yeah. So this kind of a situation we had faced some time back. It was a surgical surprise. We did a decortication, simple decortication for an empyema, and the histopathology came out to be mesothelioma. So how do you deal with that?
Excellent
adjuvant
question.
Therapy, what do you advise?
Yeah, excellent question, Shilpa. This has happened a few times in my clinical practice as well. I have gone in thinking I was dealing with empyema. I did the decortication, and then the histology came back as mesothelioma. The true answer to this is you send the patient for chemotherapy, because presence of infection and all that, this guy is not fit for any aggressive treatment. And the decortication was certainly not what I would do for a mesothelioma. So you hope for the best. If you can get rid of the drain, that's great.
Yeah.
And then you send the guy for chemotherapy. That's what I would do. It has happened to me at least 3 or 4 times over the years. And all I've done is, the guy was anyways not fit, because the fact that he came for empyema surgery is already compromised. Okay, next. Any more last questions? Or everybody?
Hi, sir. Saransh here, sir.
Hi, Saransh. How are you?
Good, sir. Thank you, sir, for this excellent talk. Just a small question. Sir, what's your opinion on restaging after NACAT in mesothelioma?
Restaging after what?
After chemotherapy? Chemotherapy.
Oh, neoadjuvant chemotherapy. Okay.
Yeah.
I think you should ideally restage everybody who undergoes surgery. It's the same principle as lung cancer surgery. The guidelines don't say anything about it. But as a surgeon, I would never believe the PFTs, because chemotherapy is going to have its effect. So if I'm going to put the guy through a major, supra-major lung resection, I want repeat tests to be done. And the guidelines say that all tests before surgery should be less than 4 weeks old. So if you've given him neoadjuvant chemotherapy, already the window is gone. So I personally like at least a CT scan to be done, if not a PET. And anyways, if he's had chemotherapy, he's not ready for surgery for 4 to 6 weeks. And most chemotherapy people will actually repeat a PET scan at 6 weeks. So for us, I don't like to operate on people and find surprises in the chest. I want a live patient. Live patient in, live patient out. That's the most important thing. Okay, guys, thank you very much. It's been great. I really enjoyed this. And,
Thank you.
I need to stop the recording.
Thank you very